Our next speaker is Iracema Leroi, a long-standing friend of the masterclass, from being a participant through consultant senior lecturer, professor of aging and psychiatry at Manchester, and now professor at Trinity. Ira, tell us about apathy, psychosis, and cognitive impairment.
Good afternoon, everyone. So thank you very much for the invitation to be here. And of course, I'm delighted that neuropsychiatry is on the program. This will obviously be a very different talk from the previous one, but just to whet your appetite for tea. So I'm working now in Dublin and part of the Global Brain Health Institute, which is a wonderful endeavor that's been funded for, which has been funded for 10 years into the future. And the idea is to train up fellows in global brain health such that they become change ambassadors for brain health. So if there's anybody out there who's interested in becoming one of our fellows, you're very welcome. And we do need to get more Parkinson's presence in our GBHI. So you can find out more from me afterwards. So my goal today is to give a brief introduction to neuropsychiatry of PD, but specifically to focus on apathy and psychosis and talk a bit about the profile, the impact of these conditions, and then touch on interventions. This is Professor Paul McHugh, who was the chairman of a department I worked in at Johns Hopkins, and he's one of the longest-serving professors of psychiatry or chairs of psychiatry in any of the US medical schools. And it was an interesting chap because at the time he was one of the very few psychiatrists in the US who really took more of a biological approach to psychiatric illness. And he came up with this term of the triadic disorder, referring to basal ganglia disorders, so Huntington's disease, Wilson's disease, and of course Parkinson's disease. And really for the first time kind of moved this idea of movement disorders into neuropsychiatric disorders. But of course, things have moved on, and of course, people like Ray Chowdhury have really pushed forward the non-motor symptom spectrum, particularly with autonomic nervous symptoms, for example, bladder instability, altered thermal regulation, orthostatic hypertension. And I imagine here most people are already using the non-motor symptom scale in their clinics. But even tetradic is probably a little bit limited, and here I was sort of testing my Greek, thinking about a pentadic disorder if we start including pain and fatigue. So highly complex and multifaceted condition. But I'm going to be focusing on cognition and psychiatry, and of course this is important because, as people are aware now, and it's well established, that over 80% of people who live with Parkinson's disease for long enough will eventually develop dementia. And if we look at the non-cognitive neuropsychiatric symptoms, particularly depression and anxiety, upwards of 90% of people will be affected at some point in the course of their illness. So it always has to be at the forefront of any assessment and intervention with people with Parkinson's disease. Now, over the years, anything that I've ever thought of doing or important questions that I've had about neuropsychiatry that I've wanted to investigate, of course, the first thing you do is go to the literature, and lo and behold, Doug Arsland has already done it. So for anyone who wants an overview of the field, simply Google Doug, and it'll be there all in its glory. So on the psychiatric side, psychosis and motivation disorders, in other words, ICDs and apathy, are what I'll focus on and talk about how they relate to cognitive impairment, particularly executive dysfunction, in which people can present without a clinical syndrome per se of cognitive impairment. Then there's PD-MCI, or mild cognitive impairment in PD, and all the way to PDD, or Parkinson's dementia. Now, one of the landmarks in neuropsychiatry in PD was in the 1990s with Helen Mayberg out of Toronto. Her group did some very elegant work using Parkinson's depression as kind of a model for affective disorders in general. And this was really important in the psychiatry field because it kind of created a kind of a localization model for how we would understand depression. In other words, really thinking about the orbitofrontal basal ganglia pathways. But things have moved on since then. And I'll come back to this slide at the end of the talk, but just kind of parking that in terms of the history. So what about the profile? I'll say a few words about psychosis. And this slide, this finding by Fenelon from 2010 is already almost a decade old, but in fact it still pretty well holds out, that about 40% of people at some point in the course of their Parkinson's will develop psychosis to some degree. And to some degree, there's of course a range of different symptoms that people can present with, all the way from what we call minimal hallucinations or minimal psychotic experiences, like passage hallucinations. In other words, the idea that is a fleeting passing by, or presence hallucinations, the feeling that somebody's present in the room. And the quotation here, if you can see this is a patient who said, "In the mornings I feel as though there's two of us. I can't phrase it very well. It's as though we're side by side going up the stairs. Very peculiar it is." And it's quite notable that this is occurring in the morning. And getting a little bit more complex, illusions of pareidolia. Now, pareidolia is, of course, things that we all experience. So, for example, if you look at the clouds and you see an image in the clouds, that's pareidolia. But people with Parkinson's disease, particularly in the early stages of what will then emerge to a full psychotic experience, will have an increased ability to experience, or increased tendency to experience pareidolias, and also an increased frequency. And then, of course, that then develops to complex hallucinations, which can be extremely complex in the form of, for example, animals coming in through the window, people being chased, visions of dead relatives sitting at the table. And this then can move into a full delusional presentation where people start interacting with these hallucinatory experiences, like, for example, feeding the children at the table, chasing the monsters out of the room. One of the most common manifestations of delusions in PD, and actually not a lot of work has been done about this, and I'm not entirely sure why this should be the case if we think about form and content, but this idea of spousal infidelity seems to come up again and again, particularly if people start increasing their dopaminergic doses. And delusions of spousal fidelity, of course, in psychiatry, you always like some names. This is called the Othello syndrome. And the consequences of this can be extremely severe in some cases. And I've had a few patients who have filed for divorce because they're absolutely convinced that their partner is having an affair. And one particular gentleman who was really quite challenging to work with in terms of trying to manage his medications was absolutely convinced that his wife was having affairs with everybody who came to the door, from the postman to the milkman and so on. And he used to bring in a tape recording that he'd put under the bed and play this for me, trying to convince me that he could hear his wife having an affair with somebody in the bed. And really all you could hear is actually somebody for hours on end moving around in bed. But he was absolutely convinced. And I've told the story before, but it's quite telling, because of course, as we tried to decrease his dopaminergic load that seemed to be really driving this Othello syndrome, it ended up with him not being able to drive because he lost some motor control. And so then he had to face this issue of what's more important, whether he could live with his wife and save his marriage, or whether he'd be able to drive. And that was a decision he had to make, and I won't tell you which one he chose. Delusions of misidentification, the Capgras syndrome can be quite dramatic. In other words, an imposter syndrome, and this is, I don't know in Parkinson's disease whether this has been the case, but certainly outside of PD, it has resulted in people killing the person they believe is an imposter, because it's an extremely disturbing experience. And another term, reduplicative pareidomnesia, in which the location is duplicated. Sometimes people with migraine can experience these kinds of phenomena. There are other visual phenomena. It's an interesting and growing field. Now, these are not psychosis related, but they do sometimes are reported by people with PD, and it's important to understand that, again, this can move outside of the psychotic realm and therefore not to be managing these in the same way. So why does psychosis develop? So sometimes when people, particularly patients, describe this, they think about it as a drug effect, as a very simple effect, but it's probably never that simple. And I think ultimately, with most of the neuropsychiatric syndromes in PD, we need to think about the combination of what the risk factors are, what the underlying pathology is, how this mixes with medication, such that we kind of have this crucible of neuropsychiatric multimorbidity. And this was a model that I wrote about a few years ago for impulse control disorder, and in which exactly this case of having a susceptibility or risk profile sets you up and puts you at risk. You then end up with some kind of stressor, where there's distress, poor coping, and so on, some kind of psychological component. You then add in your dopamine medications as your kind of susceptibility multiplier, and you end up with your neuropsychiatric syndrome. So I think you can probably, if you cross out ICD and put psychosis, a very similar model applies, that you start off with a certain profile, susceptibility profile, you end up having different kinds of stresses, other psychological, social factors coming in, dopaminergic medications are kind of that push you over the edge, and you end up with psychotic symptoms. So what is that susceptibility model? Age is a very important one. Gender, I don't know. I don't think there's any literature on that I've been able to find. Cognitive profile is very clear. There's a particular cognitive profile that increases your risk of developing psychosis, impaired memory, executive function, visuospatial function, and of course impaired attention. Dominic Fitch has done a very nice review of this area in terms of susceptibility risk factors, so I'll refer you to his paper from 2017, but he described cortical hippocampal atrophy that's quite closely associated, which makes sense, of course, because if you're thinking about the cognitive psychosis link. Likewise, pathology in terms of Lewy body positioning, tau, amyloid, and so on, and also particular changes in dopaminergic, cholinergic, serotonergic pathways, which essentially sounds like Parkinson's disease. But then if we try and think about applying the therapeutic approach with this model in mind, probably the first thing that we usually do is think about the susceptibility multiplier, and really think initially about how we can optimize or rationalize, if you will, to use a better word, dopaminergic pathways, or rather dopaminergic replacement therapy. So we try to come down and pull back very, very slowly, thinking about rebound. But then also we can attack it from the sort of the pathological pathway and instead reverse cholinergic, or in addition, reversing cholinergic and serotonergic pathways, particularly with cholinesterase inhibitors, for example, and also SSRIs. The evidence for SSRIs in terms of psychosis isn't very strong, but if we think of some of the newer antipsychotics, which I'll mention subsequently, that becomes a very interesting story. Moving on from psychosis to the disorders of motivation. Now, disorders of motivation we can think about a spectrum, going from apathy to impulse control disorders, thinking about very low motivation all the way to hypermotivation. And of course, the ICD story has been going on for about 15 years now. And everyone will be very familiar with the presentation of impulse control disorders. And generally affects about 15% of people with PD. But I think we're starting to see a slight change as the initial awareness of ICDs and the risks, and also the use of dopamine replacement therapy and dopamine agonists has been tempered over the past few years, so that's such that we're not seeing as such dramatic cases as before, and it's being caught much more quickly. But apathy as a clinical syndrome, I think, still remains very much underdiagnosed and is certainly more common than impulse control disorders, and probably affects up to 70% of people, but even higher as we move down the spectrum in terms of the advancement of the condition. And often it's masked because it's in combination, particularly with depression and anxiety, often with sleep disturbances like excessive daytime sleepiness. So if you're having insomnia and complex sleep disturbances in PD, and you're falling asleep during the day because of EDS, it's very difficult to start teasing out actually what is EDS, what is apathy, and so on. And the differential diagnosis also becomes complex if you start putting depression in the mix, again because of high rates of comorbidity. But generally with depression, you really want to sort of tease out low mood, anhedonia, guilt, negative self-view, negative worldview. Fatigue, again, fatigue and apathy, very hard to tease out, but fatigue is much more of a physical tiredness, a physical slowness, difficulty getting up the stairs because you're just too tired. Hypoactive delirium, again, there you would expect to see fluctuating attention as opposed to more of just a general flatness. And likewise, cognitive impairment, expecting to see specific cognitive changes. But I've purposely put the title up there as a clinical syndrome rather than a symptom, because apathy is a complex clinical syndrome. And whichever way you cut the pie, broadly speaking, these are the domains that emerge. Lack of initiative, lack of interest, and emotional blunting. And it's quite important to tease these out, as I'll show subsequently, because these may have different impacts on the person themselves as well as their care partners. One of the ways, apart from teasing out the characteristics of other syndromes, is that with apathy, you can look for what's called anticipatory anhedonia. Now, absolute anhedonia, that's a term that I've come up with. You won't find it anywhere. But essentially, that means a pervasive anhedonia that you see with depression. In other words, nothing makes you happy. The whole world is grey. The grandchildren come in, and the person remains flat and unhappy. And this particularly as people get older, they may be less able to articulate the fact that they are sad and depressed, but they are clearly anhedonic. Just nothing makes them happy. And so I've put here the expression, will enjoy the cake if you start to eat it. In other words, if you ask somebody with apathy who's not depressed whether they'd like a piece of cake or they'd like to watch a movie or do something fun, they will likely say, no thanks, I'm not interested, because they are missing the anticipatory, they've got anticipatory anhedonia. They don't anticipate that they'll enjoy it. If, on the other hand, give a bit of a push, and in fact, they start eating the cake or watching the movie, they will be able to enjoy it. So in other words, the hedonic response is there, but they don't anticipate it. And I think therapeutically that's a very important point, because there's always these issues that care partners ask, how much should we push? How much should we really make sure that he does these things, as opposed to just giving in when the person says, no, I'm not interested? If it's the case of apathy, then I think there's an argument based on this to give a bit of a push and say, actually, let's do it anyway, and then see. And if you really aren't enjoying it, okay, we'll step back. To be a bit more structured, there are some rating scales, of course, as everything. The one that I prefer is the NPI, or the Neuropsychiatric Inventory. And this is the NPI has been around since 1993. It was put together by Jeff Cummings. And the beauty of it, I think, is that it can, all these separate domains, of which there are 12, like anxiety, depression, hallucinations, and so on, you can pull each domain out separately and use them as a mini rating scale. And so for something like apathy, it's very helpful, because it's sometimes hard to articulate exactly what apathy is. And when you're asking care partners about apathy and the person themselves, trying to get the words quite difficult and teasing it apart from depression. So you can take the apathy subdomain out of the MPI, use that to give you a sense of presence or absence, and then you can quantify it based on frequency and severity. And that then gives you a very nice kind of starting point that you can then follow if you are doing something therapeutically, and see how that emerges. And of course, the Deal Apathy Scale, which is a quite complex scale that looks at all these different domains, but is probably better for a research context because of the time it takes. So what about this spectrum of motivation? Is it a real thing? Some would argue that yes, some no. We looked at this in a cross-sectional way, in a case control study, looking at people with impulse control disorders, apathy, and people who had neither. And there's certain characteristics that do seem to appear along this kind of spectrum line. So characteristically, compared to people with control, rather people without behavioral disturbance, so our PD controls, if you will, if you put those in the middle, people with apathy tend to be older, and they also have a later age of onset, compared to people with ICDs, who tend to be younger and have a younger age of onset. And of course, these are broad generalizations. Low dopaminergic replacement therapy, or lower levodopa equivalent doses, if you will, in those with apathy, compared to people with impulsivity, who tend to be higher. Those with impulsivity tend to be a little bit overdosed, but dyskinetic. Contrast to apathy, much more slowed down, akinetic, rigid, more cognitively impaired versus less cognitively impaired, and so on. So almost kind of sees this kind of spectrum, the two ends of the spectrum of motivation. And like psychosis, how does apathy develop? There's a number of different ideas here, but particularly dopamine obviously is a key aspect to this, because dopamine is our motivation neurotransmitter, if you will. In the extreme case, thinking about getting a dopaminergic hit through cocaine, when you get when one gets hyper-motivated. I'll remove myself from that. And what's interesting, of course, is what we see here. Now, this is a study with impulse control disorder patients. We try to do this with people with apathy as well, but couldn't quite get them into the scanner for a number of reasons. But the point here is, leaving the ICD group aside, and I realize you may not be able to see this, this group here is, I do need the microphone here, don't I? That's a control group with people without behavioral disturbance, and you can see here that they have a blunted response to dopamine in terms of reward type tasks. And we can really kind of see there in the ventral striatum the response to that. And that gets reversed when people take dopamine therapy. In other words, without dopamine therapy, you have a blunted response to reward in various kinds of tasks. And that potentially is what we're talking about in terms of the apathy pathways. What about serotonin? There's a couple of interesting fMRI studies looking at serotonin depletion in early PD, but also associations with REM sleep behavior disorder. There seems to be some kind of link there as well, which makes it quite difficult in terms of trying to tease out what's your sleep disorder and what's apathy, or perhaps these are part of the same kind of syndrome. And thinking about the classic Braak stages, you can kind of map these syndromes on, and again, apathy and depression and anxiety, looking at that kind of that brainstem pathology as it moves into the locus coeruleus and the dorsiraphe nucleus, affecting serotonin and norepinephrine. So therapeutically, can we attack these? Yes, with dopamine and serotonin. Again, in this case, rather than psychosis where we're trying to get our dopamine replacement therapy slightly lower, here we're trying to optimize it. But of course, it can become quite a challenge if we think that people tend to be older, later age of onset, for example. They may be less able to tolerate an increase in the dopamine doses because, of course, that may flip them over into cognitive impairment and delirium. So it becomes a real challenge, despite the fact that the apathy seems to be driven by the low dopamine. There's some emerging evidence about the use of SSRIs. It's not entirely clear at this point because of the size of the RCTs. And of course, there's a cholinergic story here as well. Not enough really to say that we have a definitive answer, but the point about cholinesterase inhibitors and apathy, outside of PD, in the Alzheimer's disease studies, the neuropsychiatric symptom or syndrome that responds best to cholinesterase inhibitors is in fact apathy. We don't really have that evidence in PD, but it's an interesting story nonetheless. What about the impact? How does this affect people? First of all, we know this old study, this classic study from Chris Getz from 1993 still holds that people with visual hallucinations, that's the number one factor in terms of institutionalization. And therefore, when that slippery slope, that neuropsychiatric slippery slope starts to appear, we need to be very careful about factors that may be precipitating care or breakdown. And of course, associated with increased mortality. What about apathy? In this particular study, we looked at both apathy and the ICDs, looking at the impact, or rather the association with disability and health-related quality of life. And we saw significant impacts. And if you look here at the quality of life illustration here, we can see that impulse control disorder, with all its chaos, marital breakdown, bankruptcy, and so on, in fact, the impact on quality of life of apathy is pretty well the same. So it's not insignificant, despite the fact that very often we leave it unrecognized. Now, coming back to that syndrome of apathy, we talked about lack of initiative, lack of interest, but also emotional blunting. And the emotional blunting bit is particularly interesting. And so what we thought we would do is tease that out and see whether that had a differential impact on people in terms of their outcomes, in terms of the other aspects of apathy. So we took a group of people, divided them into those who had apathy, those who didn't, and within the apathy group, classified those who had apathy with emotional blunting and those who didn't. And in fact, across the all range of different outcomes, disability, quality of life, as well as care burden, significantly worse outcomes in people who had emotional blunting compared to those with apathy without emotional blunting. And this is controlled for a range of different factors such as age, duration of motor symptoms, UPDRS motor score, and cognition, as well as levodopa equivalents. In other words, this idea of emotional blunting is significant. And the way it manifests, of course, is that patients come in, or care partners come in, and complain that, the person isn't interacting anymore, that they don't love me anymore, they're not interested in me. And so it's quite a complex phenomenon. And when we talk about apathy and trying to manage it, very much the focus is on the impact of carers. But what about the person themselves? Do they suffer with apathy? It's not entirely clear, and it's something that we've asked ourselves for quite a while. And so what we did, we went to a group of people with apathy to try to understand what their qualitative experience was. Now, this was a small study of 7 people, and this is probably the only time you'll see qualitative data at this conference, apart from perhaps the GDNF study, which we may be able to see later on. But qualitative studies usually look at small sample sizes, between 8 to 12 people. So this is a small sample size even for qualitative studies, but you can imagine how hard it would have been to get people with apathy to participate in extensive interviews. But we did it nonetheless, and we came up with some very interesting findings. Sorry, I may not be able to read the white there. So, for example, think about the social context of apathy. One of the participants said, sorry, I can't read it myself. They say, "Come on, you lazy bugger, get something done." This was his experience of apathy. And this idea of laziness is very important, that often if people, meaning care partners, don't understand what apathy is, the accusation of laziness comes to the fore quite quickly. And so there's a very important element of education and understanding about the clinical syndrome with regards to care partners. I hate at the end of the day if I've achieved nothing. So this feeling of not being able to function the way you want simply because you just don't have the drive and motivation. The apathy creeps into jobs that I used to be able to do, and can no longer do. Again, not because the person can't function, because motorically, for example, or their function impairment isn't that bad, it's because they actually just don't have the drive. And so they sit there and the day passes by. I had a patient who was quite an extreme case, who had his apathy to such an extent that he would sit in the sun on one occasion, in the sunroom, and his wife went out, leaving his lunch and so on, and his water bottle for him. But his apathy was such that he sat in the sun for 8 hours, and by the time she came back, he was utterly dehydrated, hadn't touched the sandwich, hadn't touched the drink. Right, what about linking cognition and neuropsychiatric symptoms? So this is kind of the model I use. It's a bit of an artificial heuristic, but I think it can be helpful nonetheless. And I say it's a bit artificial also because we know that people can present with quite significant cognitive impairment even in the earlier stages of Parkinson's. But broadly speaking, if we think about the motor trajectory, the cognitive trajectory follows on. So mapping on our psychosis trajectory, again, in the early stages, starting with minor hallucinatory experiences and illusions, then moving into hallucinations where insight is lost, and finally the full-blown presentation of delusions, hallucinations, loss of insight, confusion, moving into delirious states. And again, like cognition, this type of presentation can present early on as well. If it's very early on, then we really start to think about DLB as our clinical diagnosis. Can we map apathy onto here as well? Again, probably not premotor, but certainly in the early stages. And some of the ways we can look at this, of course, are with the number of longitudinal studies that are coming out, like, for example, the PPMI, the ISCL study, and the Oxford study. And using these data sets, I'll just move on from that. Oh, actually, sorry, I'll come back to that. The point, I'll have to change my talk, sorry about that. The point about these, of course, is that we're coming up with these profile of risk factors that look at cognitive decline. And I won't go into the detail, but broadly speaking, they can be lumped into these kind of categories in terms of the proteinopathies, the neurodegenerative changes, the neurotransmitter deficiencies that are all the risk factors, and the abnormalities in connectivity and function. But the point I wanted to make, of course, that you can also use these data cohorts for looking at the behavioral predictors of cognitive decline. So leaving all your biomarkers aside, what about the behavioral predictors? And if you can see here, this is really just a timeline of the evidence as it's emerging. Doug Arsland already looked at this question in 2003, showing that hallucinations are quite an important predictor of cognitive decline, overall neuropsychiatric load, apathy, and REM sleep behavior. So one of the more recent papers, sorry, this was the one I was initially looking for from the PPMI data, again, is a paper by Dominic Fitch, and he looked at risk factors for psychosis and also the trajectory of decline 3 to 4 years post-follow-up. And what he showed here is that depending on the point of the onset of your psychosis, predicted the severity and the timing of your cognitive outcome. So the green line here is the most severe, such that those are the people who presented with psychotic symptoms 1 year after the onset of their diagnosis, or 1 year after the diagnosis, I should say. And at the 1 year point, they had the worst MOCA scores. The next group up is the red line, onset of psychosis at 2 years, and then following that, onset at 3 years, and you can see here, later onset of cognitive impairment and MOCA score. So what about apathy? Now, we've not looked at the PPMI data, but initially we looked at this in cross-section, just comparing people with clinically diagnosed MCIPD versus PDD versus intact cognition across the range of different neuropsychiatric symptoms, so purely in cross-section. And the key finding here, and I realize this is a little bit difficult to see, the key finding I think that's important is that apathy was the only neuropsychiatric symptom that differentiated people with PD-MCI from normal cognition in PD. But of course that was very much tied in with the neuropsychiatric, with the cognitive profile, unlike depression and anxiety, which was quite a surprise. But what we then did is decided whether we could look at this in more detail to try to understand, in fact, whether these cognitive emotional processing changes in apathy might be borne out. And so we did a number of things. For example, we looked at decision-making using the Iowa gambling task. We looked at executive function using the Wisconsin card sort test. We looked at emotional processing using the facial emotional recognition task. And what we found here on the right-hand side, in fact, that people with apathy compared to people without apathy, had very selective impairments in attention and also impaired recognition in a number of these facial recognition tasks. So not only are people not expressing their emotion, but they are actually not recognizing emotion as well, which again feeds into their lack of expression, because if they don't pick up happiness or joy in someone, then again it's hard for them to have an emotional reaction. But those were cross-sectional data. What about longitudinally? Now we have a slightly smaller longitudinal data set here of 104 people with PD, and this is my lovely colleague Glenn Martin here, who's a very clever biostatistician, and he did some very interesting longitudinal models using this data set across 3 years, and essentially what he found was cognition and apathy travel together. So as your cognition declines, so does your apathy, so they're extremely closely linked, which goes back to the data that I showed that people with apathy have significant and noticeable profiles of cognitive impairment. So strengthening the case that apathy actually, rather than a behavioral syndrome, is a behavioral cognitive syndrome and potentially a very important marker of cognitive impairment. And then, of course, moving out of PD, MCI, once you hit PDD, you get this whole panoply of different neuropsychiatric symptoms coming together. So, what about interventions? Fixing the glitch, in other words, what are the pharmacological approaches, of which there are some, but not so many? And ultimately, this is the goal that we're aiming for. This is a classic concept of the motion-emotion conundrum. And I think patients and their care partners understand this very well, that this is what we're trying to achieve, just like our chap with the delusional jealousy. In other words, that if we want to be emotionally healthy, we might have to compromise a bit on the motion. If, on the other hand, we want to be physically able in terms of our motor function, we might have to compromise a bit on the emotional side. And coming back to our timelines, what I started with, so I've put in a few more things, because actually it's been quite a relatively exciting time over these last decade or so. And the landmarks here, of course, are the clozapine study, the RCT, in the 1990s, and this allowed the specific license for clozapine in PD psychosis to be granted. Now, having said that, clozapine is still hugely underutilized, although it is still the most effective antipsychotic for PD psychosis. And of course, there probably aren't too many psychiatrists in the room, but in the psychiatric doses of schizophrenia are significantly greater than what we would use in people with PD. We were really starting with extremely low doses, for example, 6.25 milligrams, and really trying to titrate up and see how people respond. Because clozapine is a very dirty drug with significant side effects, not only agranulocytosis, but also significant risk of falls, for example, GI disturbance, and so on. And so the list goes on. All the things that you don't want to have in a person with PD, particularly in moving into the advanced stage, clozapine will do. So it's a difficult drug to use in that regard. On the other hand, it still is the most effective. Then, of course, in the 2000s, we had the EXPRESS study, which led to the licensing of rivastigmine for PDD, and still is the only licensed drug for PDD. And then more recently, pimavanserin, which here in the UK, we were part of those trials, but unfortunately, we've not got a license for pimavanserin in the UK. And here's your serotonin story, because, of course, this is a selective 5-HT2 inverse agonist, but it is licensed in the States. So I think that's very interesting in terms of moving the field forward and the potential for where we might go. So, thinking about our little heuristic wiggly line here, I hope people can see that. So I've just put a few ideas clinically about how we might intervene, again on this timeline. So when people initially present with minor hallucinations, insight intact, they may not be necessarily very distressed, and I think that's a key factor. If the person is managing to live with these phenomena, then education and explanation is probably enough. But still, it's worthwhile reviewing their dopamine replacement therapy, seeing whether any changes can be made, a slight tweak down or up, depending on how they present. It's very important to eliminate or reduce the anticholinergic load. And of course, enhance sensory function. And I put there enhancing sensory function because, of course, particularly visual impairment is one of the precipitating factors for visual hallucinations. So make sure people's eyes and ears are okay. And this is a particular area of interest of mine right now because I'm running a study about enhancing vision and hearing in people with dementia outside of PD. And it's remarkable the very, very high rates of people who aren't wearing hearing aids when they should, or who are wearing outdated glasses, or have cataracts that haven't been detected. So these are important things to think about. As things progress, start thinking about supportive interventions. Explanation education is absolutely the hallmark of what needs to happen here, both with the person with the condition, but also care partner. And I've put here cognitive testing, not necessarily as an intervention in terms of helping the person, but this is really the point at which it triggers the need for cognitive testing. And the alarm bells go thinking, are we starting to move into cognitive impairment, potentially dementia? So cognitive testing really needs to be thought about when these symptoms become worse. And then finally, again, thinking about other interventions. Now, I've put psychological therapies here. I'll say a few words about this in a minute. Right now, for psychosis, we have no particular psychological therapy that has been tested or certainly approved. But in schizophrenia, there's a small growing literature on CBT for people with psychosis, with chronic psychosis, to help them understand and manage their voices. And there's some discussion with the SHAPED group, that's one of the big studies funded to look at psychosis in PD, as to whether those kinds of approaches can be adapted for people with Parkinson's disease. So I think it's an interesting area that's potentially developing. And then, of course, thinking about cholinesterase inhibitors as the first-line therapy. Maybe a role for memantine isn't entirely clear. And, of course, people do consider quetiapine. However, the actual antipsychotic bang that you get for your buck is probably meaningless because the doses people can tolerate in Parkinson's are really not antipsychotic doses. So all you're really doing with quetiapine is helping the person have a little bit of an anxiolytic effect and possibly help their sleep, unless it puts them entirely to sleep and they have excessive daytime sleepiness. And then, of course, finally, the role for clozapine. So in the last 5 minutes, thinking beyond fixing the glitch, beyond the impairment in terms of our medications and pharmacological approaches, I'm going to touch on the broader consequences of dementia, psychosis, and apathy, and thinking about, again, disability and handicap, because I think this is extremely important of where we're moving to in terms of the neuropsychiatric side. So the non-pharmacological approaches. And again, back to my timeline, these are the kinds of things that people are starting to look at: mindfulness, resilience, quality of well-being, coping, all from the psychological therapy side. And I wasn't at the talk this morning with Bas Bloem, and I hope he had a positive message about non-pharmacological interventions and he didn't just diss the entire field, because if he did, I'm going to counter him by showing that actually there's quite a lot of work that's happening right now. One of the initiatives is the Mind and Movement Project that's led by Jane Simpson out of Lancaster and supported by the British Psychological Society. And essentially this is a very nice initiative to look at all the information and all the studies of psychological interventions for movement disorders, and PD is a big chunk of that. So that should be available by the end of the year, and hopefully we can get that distributed to people, which I think will be very, very helpful. And also be extremely helpful in knowing where the gaps are and where we need to put our research efforts. But already there's a range, and we can probably fill in most of these boxes already because there's a range of different interventions, most of them being CBT. There's a few studies for CBT and depression, anxiety, and of course impulse control disorders. That's David Okai's study. For sleep, also we have a couple of studies looking at insomnia-based CBT, a number of mindfulness studies, brief psychodynamic psychotherapy. There's a couple, probably not that helpful, and other interventions like eye movement desensitization and reprocessing therapy. And what about the cognition-based therapies? We're coming out with a Cochrane review of brain training very shortly, probably again by the end of the year. And there's an increasing number of brain training type interventions for people, particularly with MCI PD. Linda Clare led the cognitive rehabilitation study, which adapted cognitive rehab for dementia into people with Parkinson's disease and showed a positive result in a small pilot study. And of course, there is our own cognitive stimulation therapy adapted for people with PDD and DLB, which is the INVEST study. And I'll just briefly tell you about that before we finish. So just keep your eyes out for the Cochrane, which we hope will be published before the end of the year, but that's specifically about brain training. And just finishing up with INVEST, and the point I want to make about INVEST, which I think is quite important, is this concept of why doctors fail. Now, some of you may remember the Reith lectures from 2014 by Atul Gawande, and the point he made is as follows. Much of failure in medicine remains not due to ignorance, in other words, lack of knowledge, but due to a failure of using the existing knowledge. And this is where we come into CST. Cognitive stimulation therapy has been widely used for many years, but it hasn't been used in Parkinson's. So what we did with the INVEST study is we followed this dictum and we took cognitive stimulation therapy and we adapted it through a whole process of adaptation and consultation with people with PD to come up with a Parkinsonized version, if you will. And then we went on to test it in 76 dyads. And our first publication in Journal of Neurology came out yesterday, so that's absolutely hot off the press. So I won't go into the details of what CST is, because most people here will know that, but essentially it's a supportive therapy in which people work with a partner, a care partner, or a professional therapist, looking at a number of different cognitive activities, but also there's an element of reminiscence. And the idea is that you don't ever fail. In other words, it's very much looking at your opinions about things, stimulating your thoughts and your ideas, rather than actually testing your cognitive abilities. And it's generally very well received. So I won't go through the quantitative, I'll just briefly give you some of the qualitative experiences that people had as a result of the therapy. So for example, one person, I think it was a carer, said it was great to see him getting involved and feeling valued. His experiences were very meaningful, meaning as he went through the therapy. He had a feeling of well-being. There were times when we laughed, and I don't think we used to laugh a lot. Again, what I didn't mention here, of course, that the therapy was being delivered by the care partner. So the care partner goes through brief training and works with the person with dementia using a manual. And here you can see one of a patient and her son working on one of the tasks in the manual. I think I'm starting to think in a more structured way. It's keeping my brain ticking over a bit further. And this is again a care partner. I didn't expect the reaction from Dad. He was so interested, so wanting to take part. So thinking about the apathy, again, very interesting. Seeing the banter between them, this is between a grandchild being the therapist and the grandfather. The banter between them, between the young and the old interaction, he was very good, he responded, it was really fun. In other words, tapping into this apathy, finding things out about Mom that I didn't really know. And just to end up, I hope everyone here is familiar with the APPG initiative that was led by Baroness Gale, and many people here might have testified at that. Now, this was specifically about anxiety and depression in Parkinson's, but I think the findings were very important, and there were a few key things that really pertain to what we've talked about today, so I urge people to take a look if they haven't seen it. But really it was the findings from the witnesses that really suggested this idea that one of the reasons we struggle with neuropsychiatry and PD is because of the split between the mind and the body. The split between the mind and the body, not in terms of our own conceptualization as clinicians, but particularly in terms of services and commissioning. And this was one of the quotations, this idea of institutionalized dualism. In other words, whereby we have a system of institutional design, language, politics, training, culture, economics, which unhealthily separates the physical and the mental domains. And this is one of the core things that really means we struggle with bringing the mind and movement together. So I will end there, and thank you very much.
Thanks, Ira. Delighted to report that Baz was very much on the same page.
Good.
Words like resilience, exercise, mindfulness, and so on. It's tea time now, but is there anyone with a quick last question for Ira?
I'm a psychiatric nurse.
Yes.
I'm a psychiatric nurse and have been for the last 25 years. I turned to the dark side of Parkinson's nurses about 10 years ago. And one thing that I am constantly surprised about is why people with Parkinson's don't seem to kill themselves, put it very bluntly. Is that, after listening to your talk, do you think they're that apathetic when they're depressed that they don't do it? Do you think it's because perhaps they've got such a good support package from the Parkinson specialists?
That'd be a great thing to think.
I mean,
So,
have you got
fantastic to everybody in the room.
Yeah, absolutely. Have you got a theory about Parkinson's
I
and
think
suicides,
there are a
or?
number of answers to that. First of all, generally the level of depression that people experience tends not to be as profound as people outside of PD. Often depression is shorter, briefer experiences. Apathy may be one aspect, because of course we all know the data from SSRIs as people, even with non-PD depression, become more activated. That's when their suicidal risk becomes greater, because their mood is still low and they still have negative perceptions, but of course then they have the drive to do something. So I think the fact that there's an overlap with apathy is quite interesting. The exception, and in fact, you'll notice from my slide when I talked about depression, I didn't put suicidality on there. I talked about negative self-perception and low mood, but not suicidality. The exception, of course, is dopamine withdrawal syndrome. When people, for example, have had ICDs and dopamine agonists have to be withdrawn very quickly, that's when you can have a profound dysphoria and people can become extremely suicidal, and there have been some deaths, and that's really the high-risk group. So be careful about thinking no suicide in PD. Actually, that's the group you really need to be careful about because they just plummet. So,
Thank you very much.
Yeah, brilliant question. Thank you. Let's break for tea. Back at 3:30. Thank you to Alan. Thank you to Iracema. Enjoy your tea.